So tonight we'll be going over chapter 22, Toxicology. Busted open with these National EMS Education Standard competencies. Some stuff we'll be going over with toxicology. All right. All right. Getting it started. So every day we're going to come into contact with things that can potentially kill us, to include poisonous items. So what it's saying here is that acute poisoning affects over 2 million people per year. That's a lot of people, 2 million people. And then chronic poisoning is more common. And it's just because chronic poisoning, it's the ongoing thing, right? Happens over and over again. However, as it says here, the deaths that are caused by poisoning are fairly rare. So the rate of death as a result of the poisoning in children have decreased steadily since the 1960s due to child-resistant caps. So not as many kids can get into those child-resistant caps and eat up on medications. The deaths that are caused by chronic poisoning is going to be by the adult population because of drug abuse, as you can see there. Drug abuse is up. Kids eating out of medicine cabinets is down. All right, so identifying the patient and the poison. So toxicology is going to be the study, because it's an ology, right? It's going to be the study of toxic or poisonous substances. A poison is going to be any type of substance whose chemical action can damage body structures or it can impair body function. That's a poison. A toxin is going to be a poisonous substance produced by bacteria, such as like in your animals, your plants, that acts by changing the normal metabolism of cells, or it destroys them. So toxins can have acute or chronic effects. Substance abuse is going to be the misuse of any substance to produce a desired effect. Right? Another definition. So a common complication of substance abuse is going to be overdose. And when a patient, so what that is when a patient takes a toxic dose of a certain type of substance or of a substance. So your primary responsibility as an EMT and to the patient is that to the patient that has been poisoned is to recognize that a poisoning has actually occurred. So all you got to do is recognize that a poisoning has occurred. All right. And we'll talk about today how you're going to see those signs and symptoms and how we're going to do our assessment to find out if that's what is going on. All right. So for your own safety, you have to pay attention to your surroundings, or you could also become exposed to the very same substance. So what is a common thing that our EMTs and police officers, firefighters are starting to get exposed to now? Does anybody know? It's becoming more common than what it needs to be. Let's say that.
Fentanyl.
That's right, fentanyl. All right. So knowing what those signs and symptoms are of somebody that's been exposed to it is very important. And being able to get it early and figure it out early. All right. So we had a house a long time ago that showed up to the house. The guy had overdosed, showed up. The police officer was performing CPR. I got there, checked him out. Oh, he's Narcan candidate. Hooked him up with Narcan, and he came back walking and talking. Or not so much walking as much, but talking. Didn't really tell us what was going on. Come to find out later on, the whole house had fentanyl all over it. It was actually a fentanyl house. They were selling it out of there and everything else. And I never saw any while I was in there at that time, but it could have just as easily been on him, door handle, or anything in that house could have had it on it. So it's something to think about afterwards. But they ended up finding a lot of fentanyl in that house. This was several weeks later that they ended up getting busted for it. All right, so just like with fentanyl, where we were talking about, so very small amounts of it are poisonous. It can be poisonous and can do very much so can do considerable damage or death. So if you suspect that an ingestion to an exposure or an exposure to a toxic substance has occurred, you need to notify med control and begin emergency treatment at once, as soon as possible. So the signs and symptoms are going to vary, and depending on whatever specific agent you've been exposed to. So there's some signs and symptoms of specific types of overdoses there. All right, remember this term here, or these this acronym here, sludge 'em. It's a good one to learn, especially for our firefighters that plan on doing hazmat any time in their career. So if it's possible, while obtaining the sample history from a patient, you want to ask the patient, if you can, what substance did you take? When did you take it? Or when did you become exposed to it? How much did you ingest? Did you have anything to eat or drink before or after you took it? Has anyone given you any type of antidote or any substance orally since you ingested it? And then also, how much do you weigh? Get those out of the way before they pass out or become obtunded, especially the weight thing for purposes of knowing how much of a certain type of drug, depending on what the substance was that they were poisoned by. So you're going to try to determine the nature of the poison. Look around in the immediate area. There may be bottles, open bottles. There may be, some things to look at when you're looking at the pill bottles. Also, is how much is in there, what date was it filled, and what is the prescription? What is the dosage? How many times are they supposed to be taken a day compared to how many pills are left in the bottle? Happens a lot. And it happens on purpose, and it can happen on accident as well. So making sure that checking the remains of any chemicals, the remains of any food or drink items, even if there's an overturned or a damaged plant. So there are certain plants that people keep in their household that are very poisonous. So you want to make sure that you take those suspicious items to the ED with you, if you're able to. And then containers at the sea can provide also other types of critical information, such as the name and the concentration of the drug. You have the ingredients, again, the number of pills that are originally in the bottle, the name of the manufacturer, and then whatever the prescribed dose is. And you'll get in there and you'll be counting pills. I've done it on tons of occasions where I end up sitting there and I'm counting pills out to make sure that that it wasn't that, or it was that could be the issue. So if the patient vomits, want to make sure we check it for pill fragments. And then if you see anything unusual, make sure you document it. Documentation. If you didn't document it, it didn't happen. And that doesn't always mean that's a good thing. So how you provide the treatments is going to depend on how the poison got into the patient's body in the first place. So the 4 routes to consider are going to be your inhalation, absorption, which is through surface contact, ingestion, injection, and then all 4 of those routes of poisoning can lead to life-threatening conditions. All right, so in this figure, you can see the 4 routes that the poison can enter the body: inhalation, absorption, ingestion, and injection. So talking about inhaled poisons, we want to move the patient into a fresh air environment as quickly as possible. The patient, they may require supplemental oxygen, so just be ready to administer the supplemental oxygen. If you suspect that there's a presence of some sort of toxic gas, you need to call for a specialized resource, such as like your hazmat teams, so they can come out and they can do monitoring. All right, so some patients may need decontamination by a hazmat team. So after removal from the toxic environment, they may need to get showered down, right? Need to get scrubbed down. So all patients who have inhaled poison are going to require immediate transport to an emergency room. So we need to be prepared to use supplemental oxygen via non-rebreathing mask, or if we need to provide that ventilatory support, that mechanical breath, right? With a bag valve mask if it's necessary for that patient. Also, you always want to make sure that you got your suctioning unit available in case the patient vomits, because it can be pretty highly likely. All right, so some of your patients may have inhaled poisons to commit suicide in a vehicle. I've seen that a few times, the chemical suicides. So you just got to make sure that you're very cautious when you're coming up to those vehicles where that may be suspected. If you're coming up to any vehicle where the windows are closed off or the windows are darkly tinted or what have you, and somebody's suspicious that this may be going on, your first instinct shouldn't be to go up, start breaking windows or trying to snatch doors open or anything like that. Take a look in the seats or take a look in the back seats or anything like that to see if there's any type of containers, pots or pans or anything like that that's open. Any type of smells or anything like that. Your best bet is if there's somebody laying in a vehicle that looks obviously like they've expired, then to make sure you call a hazmat team before you start trying to open any doors or anything like that as well. So if you open that car door, you can become the next victim. All right, absorbed and surface contact poisons. So that can affect the patient in a whole bunch of ways, right? So skin, mucous membrane, or eye damage can be caused. Chemical burns, rashes, or lesions, systemic effects, and then also it's going to be very important to distinguish between contact burns and contact absorption. So knowing the difference between what is a burn and what was an absorbed poison. So some signs and symptoms of absorbed poison are going to include what you see here in this list. So a history of exposure, liquid or powder on a patient's skin, burns, itching, irritation, redness of the skin, typical odors of resistance. So all of that is going to require that you are dressed out, right? You have your proper PPE on. So emergency treatment for a typical contact poisoning is going to include the following. So avoid contaminating yourself or others. So while protecting yourself, remove the substance from the patient as rapidly as possible, as quickly as possible, and remove all contaminated clothing. And then flush and wash the skin. That's going to be very important. Flushing and washing the skin. If there's any type of dusting on them or anything else, getting as much of that off as you can before you start flushing everything down. That's going to help as well. There we go. So if a dry powder's been spilled, brush off the powder and flood the area for about 15 to 20 minutes. Then wash skin with soap and water. If the liquid spilled into the skin, flood for about 15 to 20 minutes. All right, if a chemical agent is introduced to the eyes, irrigate them quickly and thoroughly. So you can see that they're using a nasal cannula, and they're running it through the lines of a nasal cannula. Pretty clever. But you always want to make sure you're running it from the inside out to the side. What you don't want to do is have them facing this way, you dripping drops in their eye, and it going into the other eye as well. So you always want to make sure you can isolate where the flushing goes. All right, so many chemical burns occur in the industrial setting. So in those industrial settings, they do have these safety showers. It's usually got a pull handle and an alarm on it as well. They should be checked relatively regularly. Should be. Is there anything that's reactive to water? Yes, absolutely there is. Absolutely there is. And in the industrial setting, they do have those things that are reactive to water. They have those chemicals. And generally, that's why we pay attention to our signage when we come in. So you have for your transportation or your DOT items, you have your hazmat placards, and then on your facilities or buildings, you got your 704 diamonds, right? The diamonds with the different colors on them. So making sure that you have an ERG in your book or in your vehicle or what have you is going to be very helpful. Knowing that an ERG only lasts for how long? Can anybody answer that? How long an ERG lasts on scene? Of a hazmat?
Ask the question again.
How long does an ERG generally last on scene? How long are they usually good for?
I don't know. Usually I toss the ERG out the window as I'm driving away.
So about 30 minutes. So they last for about 30 minutes. Is about as long as it's good for on scene. Then after that, that's just for initial response is what an ERG is for. So knowing that you have that, it's good for about 30 minutes on scene. After that, we need to rely on the hazmat teams to come in and start doing their monitoring and everything else to kind of hone things down, or their research and information crews to hone things down for some of these hazmat settings that we're looking at. Those hazmat teams, that's one thing about hazmat is that it's slow. It's a slow process, as it should be. Because it can be a dangerous process. Let them do their job, and if you're a part of one of those teams, just know it is a slow process. You got to slow things down. One thing to make sure of is that if you or your team members are exposed, that you can get decontaminated relatively quickly and thoroughly. And then along with that, you can go and get your medical surveillance done, all that good stuff, and make sure you fill out your exposure reports. So we no longer call these material safety data sheets. They're just safety data sheets now, just SDSs that you'll be looking for. They should be in an area where anybody can get to them. A lot of them are electronic now. So as soon as you show up on a scene at an industrial complex or anything like that, then make sure you ask for that. Like, hey, do you have an SDS for the items that are in this facility? And somebody should be able to provide you with that material. So under hazardous communications, the hazardous communications regulations is supposed to be accessible. Just make sure you ask for those when you get there. All right, so about 80% of poisoning is by mouth. So things talking about liquids, household cleaners, contaminated food, plants, drugs, anything like that, by mouth. What are some of the plants that are in the house that are very poisonous to people and animals? Anybody remember? Okay. What else? There's one in particular during Christmas time everybody wants to put in their house because they're very pretty. They're very poisonous.
Chrysanthemums?
Yeah, the poinsettias. Yeah, chrysanthemums and poinsettias.
Isn't mistletoe poisonous too?
It is. It is. We don't keep that junk in our house. Mistletoe. Don't be kissing nobody up in our house. We don't do that affection stuff. That's crazy. All right, so ingested poisoning is usually going to be accidental in children, and then usually it's going to be deliberate in your adult populations. So the signs and symptoms are going to vary greatly depending on the type of poison, the age of the patient, and then the time that's passed since the ingestion. So this also signs and symptoms can include burns around the mouth, gastrointestinal pain or GI tract pain. You have vomiting, cardiac dysrhythmias, and seizures can also take place. So we want to make sure that we treat the signs and symptoms and notify the poison control center and also med control of the patient's condition, right? We want to make sure that we notify them of that. So if the patient has an altered mental status, we can you can protect the patient from aspirating on vomit. So that's your main job, right, at that point, is protecting them from aspirating on their own vomit. All right, we also need to consider whether there's an unabsorbed poison that's remaining in the GI tract and whether you can safely and effectively prevent it from absorption or prevent its absorption. Here's what you might use to prevent that absorption. So some EMS systems allow EMTs to administer what's called activated charcoal. You should always immediately assess for ABCs of every patient who's been poisoned. All right. So another thing is they have to be able to swallow this activated charcoal, right? Has anybody ever tasted activated charcoal? It's absolutely disgusting. If you've never tasted it, it's just take somebody's word for it. Charcoal toothpaste. I've had charcoal toothpaste. It actually wasn't that bad. It kind of weirds you out, the charcoal toothpaste. It's kind of weird at first, but it wasn't. It's got flavoring in it. Charcoal, the stuff that we did anyway. The charcoal suspension is very nasty. So generally, when you give it, you'll give it what I do is I give it in a small cup with a straw and cold as I can get it. I'll put ice in there for days. Make sure it's real cold. The colder, the better. And that's generally how people can somewhat tolerate it. And I've had I've had to administer it to way more kids than I've had to administer to adults, oddly enough. All right, injection poisons. So injection poisons can be exposure by injection, or it is exposure by injection. This can include IV drugs. It can include envenomation by insects, arachnids, and reptiles as well. So it's usually the injected poisons are usually going to be absorbed quickly into the body, and it can cause intense local tissue destruction. All right, killing of the tissue start to get necrotic, right, around that area. So the thing about those injected poisons, they can't be deleted. They can't be diluted, or they can't be removed from the body in the field. So we can't do that in the field. So I guess technically it can't be deleted from the body in the field. All right, so some signs and symptoms of this are going to include your weakness, dizziness, fever, chills, unresponsiveness, and excitability. So for those patients, what we're going to do is we're going to monitor the airway. We're going to provide high flow oxygen via non-rebreather at 15 liters a minute, or if they need it, if they're having breathing troubles, what have you, we may have to do mechanical ventilation, right, via bag valve mask at 15 liters a minute. We always want to make sure with these patients that we're going to be alert for any type of nausea and vomiting. So that means that we're going to make sure we have our suction close by and ready, which means that when we start to get in the truck every day, we're going to make sure that the battery for that suction unit is charged up and ready to go. Please. We're also going to remove any type of rings, watches, bracelets from the area where the injection site is at, because if swelling occurs, that can cause issues later on. And cutting a ring off is not that fun. You would think that that would be a pretty fun thing to do. It's actually not as fun as what you may think. It's kind of a pain. And then depending on the rings that they have now, like you have, I wear like the rubber rings, and I had to do that when I was flying. But a lot of people now, they don't have just gold rings, which are easy to cut off. They'll get these tungsten rings, and you'll sit there and watch somebody try to cut that thing for a long time, where if you just know that it'll break if you hit it with a hammer a certain way, it'll actually break. And then it's easy to take off. Cutting through it though is pretty tough. All right, so for your patient assessment on these, you're going to do your scene size up, right? I'm going to do BSI, is my scene safe? You're going to ask that question. BSI, you're going to say it, BSI, is my scene safe? And then your instructor is going to be like, I don't know. But, or he's going to tell you what's going on or what have you, but you have to verbalize it. So what you need to do is you need to make sure, is there any type of odor in the room? Make sure that scene is safe from anything that could, jump out and get you. You want to make sure if you see any medication bottles laying around, make note of that. Is there medication missing that might indicate that there could be a possible overdose? Are there any alcoholic beverages or containers present? Are there any syringes or any type of drug paraphernalia that's going to be present on the scene? Is there a suspicious odor or a drug paraphernalia present that may indicate the presence of a drug laboratory? So if you do have some sort of inkling that this may possibly be some sort of laboratory, the best thing to do is don't go picking everything up, because a lot of times those clandestine type labs, they're booby trapped up and everything else. So if you have that suspicion, then it's just best not to start kicking things around, picking things up, moving it, and stuff like that. So make sure you're paying attention. You also want to make sure that you keep a close eye on your surroundings. Keep an open mind when you're questioning the patients or the bystanders to avoid any type of mistaken conclusions. So when where we're getting at there is that it may not necessarily be a purposeful overdose. It could be an accidental overdose of something. It could have been a one-time wrongdoing deal. It could be, somebody down in the dumps looking to commit suicide or anything like that. Accidents happen as well. So we just want to make sure that we don't jump to any type of conclusions, right? Doesn't matter anywhere. We're going to treat every patient the same. We're going to give them the utmost of best care that we absolutely can, right? All right, for your primary assessment, we're going to determine the severity of the patient's condition. We're going to obtain a general impression of that patient.
Wow,
General impression, are they sick or not sick?
Here you go.
All right, and then obtain that general impression of that patient. We're going to assess his or her level of consciousness. So we're going to assess the LOC. We're going to assess the AVPU, right? We're going to go through AVPU, alert and oriented. We're also, if you absolutely can, which you absolutely should be learning this, give a GCS. GCSs. It will make you an all-star. And if you work with me, it is absolutely necessary. Determine those life threats. All right, so determining the life threats is going to be very important for the patient, making sure that you mitigate those life threats. And then don't assume, you don't want to assume conscious, alert, and oriented is a stable condition. Okay, with these type of patients, because it can change at any point. Remember, we talked about age. We talked about the age of the patient, how much they took, how long it was before they took it, the weight of the patient. That's all going to play a factor into what happens and how fast it happens or how quickly things can go south, right? All right, for airway and breathing, we're going to quickly ensure that the patient has a open airway, a patent airway, and then adequate ventilation. Adequate to sustain human life. So we're going to make sure they have that. If they don't, we're going to fix it, right? If the patient has a difficulty breathing, we're going to begin that oxygen therapy. Begin the oxygen therapy. And then we're going to consider inserting an airway adjunct in an unresponsive patient if need be. Okay? So if the patient is absolutely unresponsive, what airway adjunct can we insert on that patient? What is one? What is the one that I'm referring to anyway? All right, for an unresponsive patient, what would be the most likely to insert on that patient? Kings, that's definitely one that would be good. I was more getting at an OPA. And an OPA would be good. MPA, if the patient is maybe does still maintain that gag reflex, then that's good too. If your state or your protocols or your organization allows Kings or LMAs, absolutely, you can go with those if they allow those. Good stuff. Or iGel, which I think is one of the better ones. You could almost walk around with somebody with an iGel in. All right. So airway breathing, we did that. Now, talking about ensuring that's adequate, ensuring that we're giving the oxygen, we're doing that oxygen therapy. And then we want to consider inserting that airway for an unresponsive patient. If you have suction available, Those patients are going to be very susceptible to vomiting, so let's make sure we got that ready, right? Have the suction ready, have the battery charged. Make sure you check it. I can't stress that enough. Make sure you check it. And then also, we're going to assess that patient's circulation, right? So assess the pulse and the skin condition. All right. And then if you find any variations, or you could find variations depending on the substance that's involved. You see, there's a lot of variables here because depending on what the substance that's involved. All right, from there, you're going to make that transport decision. You're going to consider that prompt transport for the patient that may have obvious alterations in their XABCs, or the patient that you've determined to have a poor general poor general impression. So you see that they have a poor impression, you're like, this person's sick. They're going to get some yonder, right? The main drug we're going to be giving them folks is diesel. All right, so everyone who is exposed to the hazardous material must be thoroughly decontaminated by the hazmat team before they leave the scene. Do not pull up anywhere with that stuff all over you, with that hazardous material all over you at the ER and be like, oh yeah, by the way, we have been contaminated. Can you bust out all of your stuff in the middle of this parking lot? Somebody will get excited. Their EM guy who doesn't get a lot of work in may get excited about it, but nobody in the ER will be. So just make sure that if you do come in contact with any hazardous material, that you get decontaminated before you leave the scene. They can do patient decontaminations while on the stretcher or on a backboard or what have you. They can do a patient decontamination as well as yourself. All right, when we get into our history taken, we're going to investigate the chief complaint, right? If your patient is responsive, you're going to begin an evaluation of the exposure, and you're going to get a sample history. If the patient is unresponsive, we may attempt to obtain the history from other sources. Those other sources, who could be those other sources? Yep, family, friends, bystanders that were there. All right, so in addition to that sample history, you can ask the following questions. You can ask, what is the substance that was involved? Do you know what this person may have been exposed to? When did the patient ingest or become exposed to that substance? When did they take it? Or when did they get exposed to it? How much were they exposed to? And then you ask, over what period did they get exposed to it? Like, what was the time frame they were exposed to it? Was it over a long period of time? So it's like, if we're talking about somebody that's working around organophosphates, pesticides or anything like that, somebody that may have lime powder all over them, farmers, things like that. A lot of times that happens. And then has the patient or the bystander performed any type of interventions for this person? And then have those interventions helped thus far? And then also, how much does that patient weigh? Just get good at being able to determine weight by looking at somebody. That's probably your best bet there. But figuring out how much the patient weighs, because we may need to know soon enough. All right, for your secondary assessment, you may not have time to conduct that secondary assessment because you may be doing other things, trying to keep up, just trying to keep the life sustained. The physical examination, you want to focus on the area of the body that's involved with the poisoning or with the route of exposure itself. So a general review of the body systems may help to identify a systemic problem That's why, like when we talk about when we do our patient assessments, even though we do a focused assessment, I still have everybody go through all the body systems, right? And that's because we're trying to see is this in fact the one that it has the most issues? Is this going to be the body system that has the most issues? So make sure that when you're doing your focus assessment, that's well and good, but go over the other body systems as well. So a complete set of baseline vital signs are going to be important. A complete set. So we're dealing with an altered mental status patient. So something that I always make sure of is I go ahead and I take that. If I'm not sure what's going on, I'm doing my assessment for it, then I will go ahead and get a CBG on that patient, or I'll check blood sugar on that patient. Alterations at the level of consciousness, their pulse, their respiration, blood pressure, skin, those can be the more sensitive indicators that something may be seriously wrong in those patients. So for the reassessment, we're going to reassess, continually reassess the adequacy of the patient's XABCs, right? We're going to repeat the vital signs and then compare them with the baseline set in a little thing that we call trending, right? Trending. We're going to evaluate the effectiveness of the interventions that we provided. So if you provide that intervention, then you're automatically going to check those vital signs a little bit after, right? So did it get better, worse, or did it stay the same? So if the patient is stable, we're going to check every 15 minutes. If the patient is unstable, we're going to check every 5 minutes. So the treatment for these patients, we're going to support their ABCs. That's going to be your most important task, is supporting those ABCs. We're going to contact Med Control or a poison control center to discuss the types of treatment and treatment options that are going to be best for us. We're going to manage any type of airborne exposures with oxygen. We're going to remove contact exposures with copious amounts of water unless it's contraindicated. And we're going to consider activated charcoal for ingested poisons. Activated charcoal. So communication and documentation. We're going to report as much information as possible that you have about the poison or the chemical to the hospital. Make sure you report it. If the poison or exposure occurred in a work setting, you're going to bring the SDS to the hospital. Also, the emergency medical care, continuing on with it. We're going to ensure that scene safety. We're going to follow standard precautions, perform external decontamination. We're going to remove any tablets or fragments from the patient's mouth if there is any. And we're going to wash or brush the poison from the patient's skin if there is any. And then our treatment mainly for these patients is going to focus on support of these patients. Assess the XABCs, provide O2, treat for shock always, because it's easier to prevent shock than it is to treat it. So we're gonna try and wrap that up as quickly as possible if we can. And then some EMS systems can allow for activated charcoal to be used. Make sure that you follow your protocol. All right, so what does activated charcoal do? So activated charcoal, what it does, it binds to a specific toxin, or it binds to specific toxins, and it prevents their absorption by the body. So those toxins are then carried out of the body in the stool. So activated charcoal is going to be indicated for patients who have ingested alkali poisons. I'm sorry, take that back. Contraindicated. I didn't look at that well enough, did I? So it's not going to be indicated for these patients. So it's going to be contraindicated. So if they've ingested any type of alkali poisoning, cyanide, ethanol, iron, lithium, methanol, mineral acids, or organic solvents. And then also these patients who have a decreased level of consciousness and cannot protect their own airway, we're not going to give it to them either. So if we know that they've been exposed to these type of chemicals, it's not going to bind correctly, right? It's not going to bind. So if your local protocol does permit it, you will likely carry plastic bottles of the pre-mixed suspension. Each of it's going to contain 50 grams of activated charcoal. 50 grams of activated charcoal. So the usual dose for an adult or a child is going to be 1 gram of activated charcoal per kilogram of body weight. So 1 gram per kg. 1 gram per kg. So before you give a patient charcoal, you're going to obtain the approval from medical control. What you'll do is you'll take the bottle, you'll shake it up very vigorously, and that's going to mix the suspension in there. And then you may need to convince the patient to drink it, but you don't want to force it to them. You want to make sure you record the time when you administered the activated charcoal. So if the patient refuses activated charcoal, you're going to document the refusal, and you're going to document your attempts to counsel the patient and transport the patient for further evaluation. So just keep no, it's not. So the danger involved is that it's not going to work. So you may give somebody that and then it's not going to work appropriately. So the danger would be it doesn't work and the poison process continues on. That's going to be the main danger of it. But that's also why we recheck. Is it better? Is there improvement? Is there any type of decrease, or are we staying the same? So the effects of ingesting activated charcoal. Okay. The effects of activated charcoal are going to be your constipation and black stools. Constipation and black stools. So make sure that you educate your patient about that. So if the patient has ingested a poison that causes nausea, he or she may vomit after taking the activated charcoal, and the dose will have to be repeated. All right. Before we jump into specific poisons, let's go ahead and take a 10-minute break right quick, and then we'll come on back before we jump into specific poisons. Poison. That's because I was telling the best part of the story. That's why it's doing that. No, I said, did y'all see my many leather-bound books that I just collected over the past day and a half? My wife bought this for me. She said that instead of having a white background, it'd be nicer if I had a bookshelf. a fake bookshelf. I didn't want a green screen because the green screen just looked. Teams doesn't really have a good really have a good setup for green screens just yet. And then when I was using the different type of background, it just kept cutting parts off me and everything else. So I went ahead and changed around my desk, and she ordered me one of these little things. Thought it was pretty neat. If anybody wants to borrow a first edition copy, I have it. The lawyer attorney vibes. Nah. Hold on, let me see. Nope, there's no law books back there.
Do they really read all those law books?
Do they really read them? So
Because those books are pretty thick, and it's like many editions of just like one certain. You know what I mean?
Well, I do know people that are lawyers, and they do have lots of books, but mostly it's reference. It's reference books. So I have a lot of books. I just don't have a bookshelf. So all my books are like medical books, older medical books, stuff like that. And so yeah, it's I'll reference it every now and then if Melinda and I are having an argument or what have you about something, and I want to feel smart. Most of the time, I just do the old GTS, break open the phone and go through it, ask Google. But now the books that I have, mostly what I do, I listen to Audible. Listen to a lot of Audible books, and then what I'll do is if I like the Audible book that I listen to, then I'll buy the book and then read the book. So I probably listen to about 2 or 3 books a month. While I'm in my car or while I'm working or what have you, I listen to an Audible book, and then if I like it enough, I'll buy it. My reading list is silly, and there's a whole bunch of books, different types of books on my reading list. Audible is fantastic, though. I don't get any money for advertising them, but I will tell you that they are fantastic. All right, knocking it out. Specific poisons. So over time, a person who routinely misuses a substance may need to get increasing amounts of it to achieve the same effect. So achieve the same results. So that therein lies an issue, right? Because they're going to need more and more and more of it to get those results back. So this is called a tolerance. This is when they develop a tolerance for that substance. So when a person with an addiction has an overwhelming desire or a need to continue using the substance at whatever cost, then it becomes an issue, right? That's an addiction. So they will have that a tendency to increase the dose of that as well. So almost any substance can be abused. Almost any substance can be abused. All right, so the importance of safety awareness and standard precautions in caring for victims of drug abuse, it can't be overemphasized. So known drug abusers have a fairly high incidence of serious and undiagnosed infections, including HIV and hepatitis. And it's just because of the careless manner in which they're getting these substances, how they're injecting these substances in their body, the conditions that they're in, the environments that they're in. That's how they get a lot of these. And plus that, and while under the influence of these substances, their body systems are at a weakened state. So that's going to cause issues as well. So with these patients also, you need to expect the unexpected and remember that the drug user, not the drug, can pose the greatest threat. The drug user. All right, going on with alcohol. So many of your service calls have a connection to alcohol use. Go figure, right? Whether it be trauma or whether it be some of your medicals. A lot of your service calls will have some sort of connection with alcohol use. All right, so alcohol can damage the liver, whether it's through chronic overuse or the occasional heavy use. So the occasional heavy use is what we call binge drinking, right? So binge use can be more damaging than chronic use, depending on the frequency of the binging and the surrounding circumstances. So you're taking in a lot of alcohol, you're making yourself very sick, and those short bursts of time, it can be very damaging to your system. All right, so alcohol is going to be a central nervous system or CNS depressant, central nervous system depressant. So it's going to be a sedative and a hypnotic. In general, alcohol dulls the sense of awareness, slows reflexes, and it reduces reaction time. So it may also cause aggressive or inappropriate behavior and lack of coordination. It may also cause inappropriate behavior or lack of coordination. So a person who appears intoxicated may have other medical problems also. So people that appear intoxicated and then also may have a smell of like wine coolers or some sort of a mixed drink or anything like that. What is another illness that actually gets mistaken for a person under the influence? What's another medical problem? Right, diabetic emergencies. So my eyes itching, my contacts are drying out, I guess. Yep, your hypoglycemia, hyperglycemia, things like that. Okay. So if a person appears to be intoxicated, we also need to make sure that we're checking for those other possible problems as well. So we need to look for signs of any type of head trauma. We need to look for mental illness, toxic reactions to other things, uncontrolled diabetes, like we just talked about. So severe acute alcohol ingestion, like we talked about that binge drinking, right? It may cause hypoglycemia. So alcohol also, it increases the effects of many other drugs, and it can commonly, it's commonly taken with other substances as well. Put an eye drop in mine just a little bit. So if a patient exhibits signs of serious central nervous system depression, we need to provide that respiratory support to keep them going, right? So depression of the respiratory system can also cause emesis. All right, so emesis, what is emesis? You might tell me what emesis is?
Vomit.
Vomit.
That's right, vomit. It's another word for vomit. It's the medical term for vomiting. That's right. So it can cause emesis or vomiting. Patients in alcohol withdrawal may experience different types of frightening hallucinations, or what we call something that we call delirium tremens. All right, or what we call DTs, delirium tremens. And delirium tremens can be dangerous as well. Withdrawal can be dangerous as well, because their body can be dependent on that. Their body almost survives off that. So if it gets taken away, they go into withdrawals bad enough, it can actually cause other health issues. All right, so DTs. DTs are going to be characterized by agitation, restlessness, fear, sweating. You see all of the symptoms there. So those conditions may develop after a person stops drinking or when alcohol consumption levels are decreased suddenly. So for those patients, we need to make sure that we provide prompt transport. We need to reassure the patient and provide necessary care and emotional support to that patient as well. All right, moving on to opioids. So an opioid is going to be a type of narcotic medication. All right, and I say those like that for a reason. Opioid is going to be a type of narcotic medication used to relieve pain. An opiate is a subset of the opioid family, and it refers to natural, non-synthetic opioids. So an opiate is a natural, non-synthetic opioid. So it's named after the opium in poppy seeds, from which codeine and morphine are going to be derived from. So most of the time, that it relieves the pain, right? Or it's used to relieve pain. It's now prescription opioid drugs are going to be the most commonly abused drugs in the United States. So some people can actually become physically dependent on opioids after taking an appropriate medical prescription. All right, here's some of your common opioids and opiates. All right, so prescription opioid drugs are among the most commonly abused, like I said, in the United States, what we just talked about. And then it talks about further how people become physically dependent on opioids. We just said that. I guess I put those notes in the wrong spot. So opioids are going to be agents that they're going to be CNS depressants, and they can cause severe respiratory depression. All right. And then, of course, cardiac arrest if it's not treated promptly. So it'll cause respiratory depression. It's almost like the brain forgets to breathe almost. It gets depressed so much. And they go into respiratory depression and then some sort of respiratory arrest. And then from there, they can end up having cardiac arrest followed along. So a tolerance to these drugs develops pretty quickly. Some users may require massive doses to experience the same high. So it just keeps getting where they have to have more and more and more and more. So those drugs, they often cause nausea and vomiting and can lead to the development of hypotension as well. Hypotension. So with opioids, although seizures are uncommon, they still can occur. Patients typically appear sedated or unconscious, and with opioids, they can be sedated, unconscious, and have be cyanotic with pinpointed pupils. Pinpointed pupils. Opioids. Pinpointed pupils for opioids. All right. So naloxone or Narcan, it reverses the effects of opioids or opioid overdose. It can be given by the intravenous, intramuscularly, or it can be given intranasally. Okay. In many EMS systems, EMTs do administer naloxone, by the intranasal route. They'll put an atomizer on it a lot of times. Looks like a little cone that they put on the syringe, and then you half and half. You should half and half. So for this, it should only be used when your patient is experiencing agonal respirations or is apneic. So what are agonal respirations? What is considered an agonal respiration? So it's like the fish out of water, right? When they're doing the gulps of air, it's like a fish out of water. Agonal respirations. Remember that term, agonal respirations. You will hear that again if you haven't heard it already. And what does apneic mean? Apneic. What does that mean?
Not breathing?
Not breathing. That's right, not breathing. So because it's A, right? Apneic, so something to do with air. So no breathing, something to do with breathing. A usually means lack thereof, right? All right, a little more about Narcan. So in some areas, lay people are permitted to administer Narcan. You can find out from bystanders if the patient has been given Narcan. So it's good to ask that. The thing about Narcan is that you'll give it to these patients, and depending on why they were in that condition in the first place, some of these patients can wake up very angry with you. And because you took their highway, doesn't matter whether they were on the brink of death or not, they're going to be very angry with you. And we just have to provide that support. Don't let it get to you or anything. Just continue to provide that support and help that patient out as possible. Another thing is that it needs to be known that you give a patient Narcan, then it is highly advisable, and I would almost consider that they're not going to be rational to be able to make decisions on their own. But because what happens is Narcan will make that binding or it'll block that receptor, but it's only going to do it temporarily. After a little while, the Narcan will wear off, and then the patient will be right back to where they started. Not a good condition to be in. All right, sedative hypnotic drugs. So sedative hypnotic drugs are what we call barbiturates or benzodiazepines. Sedative hypnotic drugs. Different from opiates. So barbiturates and benzodiazepines. So they're easy to obtain and they're relatively cheap. So those drugs they're CNS depressants, and they can alter the level of consciousness. So you have that alter mental status with these patients, and it has similar effects to those of alcohol. Those patients that are under the influence of barbiturates or benzodiazepines, they can appear drowsy, they can be peaceful at times, or they can be intoxicated. So in general, those agents are going to be taken by mouth. Occasionally, the capsules are suspended or dissolved and injected. So IV sedative hypnotic drugs quickly induce tolerance, so the person requires increasingly larger doses. Once again, right? So those drugs, they may be given to people as a knockout drink or a Mickey Finn, right? To it's used to incapacitate them without their knowledge. Roofies, they should be called Flories. I don't know if anybody got that reference or how badly I butchered it. So generally, your treatment is going to be to ensure the airway, that the patient is patent, their airway is patent, and we're going to assist ventilations and provide prompt transport for those patients. All right, moving on to abused inhalants. So, something else too. Let's go back to that. So benzodiazepines or sedative hypnotic drugs. Narcan is not going to work on these patients. One way to check and make sure when we're checking our opioid patients, what is something that we generally check to see what a neurological status can hold, right? Something to do with our assessment that's going to let us know a neurological status. So when we're looking at opioids, we can find out a certain thing, and when we're looking at these sedative hypnotic drugs, we can find a certain thing. So looking at opioids, what is it that we can assess that's going to let us know that there's a larger probability that it could be an opioid drug?
Pinpoint pupils.
Pinpointed pupils. All right, and if you're on a sedative hypnotic drug, what are you looking for?
Bueller, anyone? Bueller. How about dilated pupils?
It's possible. So it's not always it. Yes, it does happen, but it's not necessarily. It doesn't hold true every time. Confusion, yes, confusion may have. Confusion may be a part of it as well. But the dilated pupils doesn't always go with barbiturates or benzodiazepines. All right, so if I come upon a patient that has pinpointed pupils, and I have a suspicion that it's caused by opiates, then I can give that patient Narcan. However, if I check that patient, they don't have the pinpointed pupils, then the likelihood that it's a benzodiazepine or a barbiturate, that Narcan is not going to bind to the receptors the same way, right? So it's not going to work the same way. It's not going to work at all. So that's something you have to consider, that you give that and like, hey, this ain't working. Well, because it may not be an opioid. So that too, and then also there was a rash of a while back people that were taking the K2 and the spices, things like that, and some people were going out there and try to load them down with Narcan, and it wasn't working. It wasn't working for them, and they were like, "Well, this is ridiculous." Well, it's because it's not an opioid. It's not an opioid. It's some other chemical reaction that they're having. So it's only going to work on those opioids. However, giving Narcan to a patient is not necessarily going to be what kills that patient, right? So when in doubt, if you use a Narcan, that's okay. You can give Narcan to a perfectly healthy person, and it may make them sick. It may give them stomach problems or what have you. Just be prepared for that. Also, your Narcan patients, be prepared to have that suction, because there's a high likelihood if you pound that Narcan in there, you're going to get vomit on you. So make sure you're paying attention to that. And if you read it in there, just because this patient is under the influence of an opioid, it doesn't mean that we have to give that patient Narcan. So why would we give a patient Narcan if they're under the influence of an opioid? What would be the reason why we're giving it to them versus why we're not? Does anybody remember? That agonal respirations, right? So if they're depressed, if they're have that respiratory depression, then they're not getting proper adequate breaths in or anything like that. We'll give them that Narcan and trying to pick that breaths per minute back up, or try to bring that respiratory recruitment or that lung recruitment back up, right? So that's how we're going to do that. Now, if the patient's breathing just fine, but they're they're asleep, then if they're breathing just fine, everything else is just fine, why wake them up? Why wake them up? Right? They're under a lot less stress when they're just taking a nappy nap. All right, inhalants. So those are going to be agents that are inhaled instead of ingested or injected. Crazy, right? So some of the more common agents are going to include like your acetones, your toluenes, your xylenes, and your hexanes. So those are commonly found in glues, cleaning compounds, paint thinners, and lacquers. You also have gasolines and various halogenated hydrocarbons that are such as like in Freon, that's used as propellants in aerosol spray cans or various other type of aerosol sprays, and they are also can be abused inhalants. So commonly they're used by teenagers because they're easily accessible, right? So the effects of inhalants are going to range from mild drowsiness to coma, and often they can cause seizures as well. So halogenated hydrocarbons, solvents, they can make the heart hypersensitive to the patient's own adrenaline. So that's going to cause issues also. We try to keep those patients from struggling. If they're with you, we try to keep them from exerting themselves. So we want to make sure that we want to use a stretcher for those patients, give oxygen, and transport the patient to the hospital promptly. For some different types of hydrocarbon poisons, alcohol poisons, do you know what they possibly may use at the hospital to counteract that? Someone that may be fuel poisoned. Anybody ever look into that? So beer. So you can actually be prescribed beer at the hospital, oddly enough. What else we got here? Hydrogen sulfide. All right, so it's going to be a highly toxic, colorless, and flammable gas with a distinctive rotten egg odor. All right, it affects all organs, but it has the most impact on the lungs and the central nervous system. So it can be used to commit suicide. It's referred to as a chemical or a detergent suicide. We talked about that earlier, right? So again, as it's saying, if you approach an enclosed vehicle with an unconscious patient inside, be alert to the warning signs, as well as containers, buckets, pots, things like that. If you suspect that to be, you suspect that the presence of a toxic gas is in there, wait for the hazmat team to tell you the scene is safe. Wait for that. Also, hydrogen sulfide can come at, depending on where you're at, depending on what type of jobs you're doing, where a victim may be. It can happen. It can happen when we're talking about patients that are below grade in enclosed areas. We need to be careful of that. I know that there are some, like, even when if you ever been to a swamp or to a creek or anything like that, and it's got this rotting smell whenever there's bubbles that come up from the water, that hydrogen sulfide can be a part of that causes our firefighters. So hydrogen cyanide, hydrogen sulfide, things like that. It's just one of the chemicals that you can be subjected to in a fire. It can, but it can be mixed up into the air. It's heavier than the air, but it can be mixed up into the air. So one thing is like for the firefighters that are here, those that plan on doing hazmat or anything, if you do get called up and you have your monitoring devices. If you suspect that that could be an issue, you always want to make sure that, one, you have the correct sensors on your gas detector. Your sensors in your gas detectors can actually, your 4 gas or your 6 gas can be changed out to be able to detect and monitor different chemicals. And then there are some that multiple sensors will be needed to detect certain types of chemicals. So you'll have to have different types to do that. Make sure they're calibrated, things like that. Another thing that happens commonly is that your hazmat members will go in there with the monitoring system and they'll outrun their monitor. It's called outrunning your sensors, outrunning your monitor. So that's where you're monitoring along and you're doing it too fast. So you don't allow your monitor to catch up and be able to appropriately sniff out that area. So that's why I say it's a slow process. Slow down and let the sensor do the work. So just keep that in mind when you're there and you're thinking about that. Also, make sure to look into the windows and pay attention. If you suspect anything suspicious, then head on out. About to lose my mind on this kid if he don't quit banging around on stuff. All right, so signs and symptoms are going to include nausea, vomiting, confusion, dyspnea, a loss of consciousness, seizures, shock, coma, cardiopulmonary arrest. So cardiac arrest. Once the patient has been decontaminated, the management is largely supportive. Just supportive. So monitor and assist the patient's respiratory and cardiovascular functions, provide rapid transport, O2, 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 O2. Okay, oxygen, oxygen, oxygen. And then also if you have a kit, or depending on what it is. All right, CNS or central nervous system stimulants that mimic the effects of sympathetic nervous system. All right. All right, sympathomimetics. So sympathomimetics, it's frequently they cause hypertension, tachycardia, and dilated pupils. All right, so pay attention to that, right? So frequently they cause the dilated pupils, tachycardia, and hypertension. So a stimulant is going to be an agent that produces an excited state, super excited state. So some examples of this are going to be your amphetamines, your methamphetamines, your phentermines, phentermine hydrochloride, and amphetamine sulfates like benzedrine, and then designer drugs. So like you're talking about Molly, ecstasy, your MDMAs, Adam, Molly, ecstasy, MDMAs. So cocaine, it can be taken in a number of different ways. It can be absorbed through all the mucous membranes and even across the skin. So immediate effects include excitement, euphoria, and it can last less than an hour. So moving off through that, smoked crack, it produces the most rapid means of absorption and can therefore be the most potent effect for these patients. So an acute overdose is going to be a genuine emergency, right? So patients have a high risk of seizures, cardiac dysrhythmias, and stroke with these because it causes so many systemic problems. So the patients can be experiencing hallucinations, paranoia, and that can place you at risk. So just make sure that you're paying attention to your surroundings. Pay close attention to your patient. Don't be caught flat-footed, right? So law enforcement officers, in this case, they should restrain the patient if it is necessary. You also don't leave the patient unattended during your transport. I cannot tell you, I've seen it. People bailing out of an ambulance because they're not paying attention. Somebody's talking. We had one. I was behind the ambulance in a fire truck, and behind the ambulance, and the door swung open on it, and we were doing about 40. Door swung open, and the patient jumped out. So we stopped, thinking we were going to have the patient to tend to again, and we did not. He hit the ground and just about hit the ground running. So he hit the ground, he rolled a few times, and then shot off into the woods. We call that AMA. Does he RUNNOFT? Against medical advice. So those patients, they're going to need prompt transport to the ED. Make sure that we're giving these patients supplemental oxygen and be ready to provide suctioning for these patients. So something else that's popped up, and we've seen people that have eaten people, attacked people with sores, cooked people in microwaves, and all sorts of crazy stuff due to our synthetic cathinones. So your bath salts. So it's going to be an emerging class of MDMA drugs. So they sell it as bath salts so that it escapes the legal restriction imposed on illicit drugs. So it produces euphoria, increased mental clarity, and sexual arousal as well. So most users of the drug, they snort or they insufflate the powder nasally. Do it through the nasal. So the effects of this can last as long as 48 hours. It's crazy how they don't put the negative things that it can do to you. They say euphoria, increased mental clarity, and sexual arousal. But they don't tell you that you may have it, the euphoria can quickly turn into, a squirrel eating somebody's face off, or people standing around you turn into large spiders that you want to attack, things like that, or that you feel like you can be a rhinoceros and go head on with a Mack truck and be okay. They don't talk about that. No, they call it euphoria, increased mental clarity, and sexual arousal. Jones and Bartlett needs to get with it. So the adverse effects. Here comes the adverse effects of this. So the adverse effects of this are going to be your teeth grinding, your appetite loss, muscle twitching, lip smacking, confusion, gastrointestinal conditions, paranoia, headache, also elevated heart rate, and hallucinations. So there's the adverse effects of it. The good effects that might happen are the euphoria and mental clarity and sexual arousal. The bad effects we're going to put on the next page that deals with appetite loss, teeth grinding, muscle twitching, lip smacking, confusion, GI conditions, paranoia, headache, elevated heart rate, and hallucinations. Still, it still doesn't tell you. So a lot of these patients too, they wind up feeling very hot. That's why a lot of times when we find these patients, they are naked. Yes, seizures in these patients are possible as well. They can be. It can lead to that. So it'll probably be secondary, but it can lead to that. Yes. So you want to keep the patient calm during transport. Consider ALS assistance for some of the patients may require chemical restraint to facilitate safe transport. Again, your Narcan, things like that are not going to help it. Flumazenil, anything like that, flumazenil are not going to help those because it's not a benzodiazepine. It's just, that's what it is. They can, some other things is too, that person can be absolutely calm and okay, or they can be a screaming fool. I've had them screaming steadily, like almost they don't lose breath, rate, tone, and stiff as a board. Just be locked out, stiff as a board, screaming as loud as possible. I've picked these patients up off the floor, and they were literally, their muscles were stiff as a board. They were screaming one person screaming top of his lungs, and I was able to grab one ankle, and a firefighter was able to grab one wrist, and we picked up his whole body like a board and put him down on the stretcher like that because he was so stiffened up. It was absolutely crazy. And then trying to hold that patient down while you get an IV in is pretty crazy as well because they get pretty violent. All right, moving on. Marijuana. So marijuana is going to be abused throughout the whole world. All right, I'm going to try and pronounce this as well as possible. THC. I can pronounce that. But it's called tetrahydrocannabinol. Yeah, tetrahydrocannabinol. So, or what we call THC is going to be the chemical in marijuana that the plant produces its high from. That's how you get its high. Inhaling marijuana smoke, it produces the euphoria, relaxation, and drowsiness. It impairs short-term memory and the capacity to do complex thinking and work. And the euphoria could progress to depression and confusion as well. So with very high doses, your patients can experience hallucinations and become very anxious or paranoid. Marijuana is often used as a vehicle to get other drugs into the body. So what they're saying is that they'll mix it into it, lacing. They'll lace it with something, angel dust or PCP or anything like that. So several states have legalized the recreational use of marijuana, and others allow for the medical use of marijuana and products that contain THC. Something else they have is what they call edibles or baked goods and candies, scored brownies, right? And other food additives that have been infused with marijuana, like what we call scored brownies, scored food, scored whatever. Now they have different places that they have restaurants that actually make these types of foods, and you can go in and order it, and it lets you know just how much, how many milligrams are in each food, and then you can order that and eat it, and then be high as a kite when you leave there. It's kind of crazy when you think about it. So ingestions can lead to cannabinoid hyperemesis syndrome. It just means hyperemesis. That means you vomit a lot, continuously vomit a lot. So it can be characterized by chronic marijuana use and extreme nausea and vomiting that's relieved only by a hot shower or a bath. All right, on what we talked about a little while ago. We talked about synthetic marijuana or spice, and it refers to a variety of herbal, incense, or smoking blends that resemble THC and produce a similar high. Somewhat similar. Not all the time, though. It's got very powerful, unpredictable effects. It may result in ranging from simple euphoria to completely a loss of consciousness. So with these patients, the thing is about them is you never know what batch is which or which one is going to act a certain way because they have to change the chemical makeup in order to stay ahead of the FDA and all the legalities with it. So they change the chemical makeup from one batch to the next. And when they do that, then they're able to sell it out there and people take it, and then it's a bad batch and things don't go so well. All right, hallucinogens that alter a person's sensory perceptions. So the classic hallucinogens are going to be your lysergic acid dithylamide, or LSD. So there's a list of commonly abused hallucinogens there. So what we're going to do is take another 10-minute break, and then we'll come on back and we'll continue on talking about other hallucinogens. All right, 10 minutes. See y'all in 10. Right. All right. All right, so hallucinogens, continuing on. So these agents are going to cause They're going to cause visible hallucinations. They're going to intensify visions and hearing. They'll generally separate the user from reality. So patients that are experiencing a bad trip, all right, a negative experience from it, are going to have things like your hypertension, tachycardia, anxiety, paranoia, things like that. So you're going to care for this patient the same that you would for a patient that's taken a sympathomimetic. You want to make sure to use a calm, professional manner with these patients. Provide that emotional support for these patients. Don't use restraints unless you or the patient is in danger of injury of any type. Watch the patient carefully throughout the transport and don't leave the patient unattended because of reasons we talked about before. And then request ALS assistance when it's appropriate. All right, moving on to anticholinergic agents. Anticholinergic. So these are medications that have properties that block the parasympathetic nerve. So the classic picture of a person who has taken too much of an anticholinergic medication is hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. All right, some important things to remember. So the picture of a person for that is going to be, picture of a person that is going to be hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. It's up on the screen, the second bullet. All right, so some common drugs that include this are going to be your atropine, Benadryl, Jimson weed. Yeah, Jimson weed and Elavil. All right, also known as amitriptyline. Amitriptyline or triptyline? Triptyline, I think it is. If I'm not mistaken. So it's often difficult to distinguish between an anticholinergic overdose and a sympathomimetic overdose. Both of the groups of patients may be agitated and have tachycardia and dilated pupils. If I could come up with a song for that, any type of rap song, trust me, you don't want to hear me rap. I'm far from Eminem or anybody else for that matter. It's more like Skittle than Eminem. So moving on with anticholinergic agents. So some tricyclic antidepressants have significant anticholinergic effects. So death from these agents, they can be very rapid. So the patient can go from appearing normal to seizing and death within about 30 minutes. So you have with those patients, you have to you really don't. I saw you the yes we do. You really don't. So the transport it immediately and consider calling for ALS backup en route for these people. Rob is blowing me up. He is like I got 5 messages from him in like 2 minutes. It's like I don't something exploded, I guess. So anyway, so absolutely make sure you call for that ALS backup. One of my last classes took a picture of me while I was teaching class, and I guess it was back whenever they had that filter that makes you look like a woman, and so they took a picture of me in class and put the filter of me looking like a woman, and then somebody then went and did the same thing, and it had the person dancing around on it or doing a song with it, me dressed as a woman singing a song, and then they posted up on social media or they posted up to everybody else in the class, and that was pretty entertaining, and that circulated for a little bit. I didn't think I looked too bad. I thought I looked pretty good. I was actually wondering if I could put that, maybe I'll do some classes in that getup with that filter on 24/7. It wasn't that bad. All right, enough of that. Moving on to cholinergic agents. So cholinergic agents overstimulate the normal body functions that are controlled by the parasympathetic nerves. So some of these can be like your nerve gases. So nerve gases that are designed for chemical warfare, or like you have organophosphates, insecticides in your insecticides. Right. Good stuff here. Love acronyms. Makes things easy to remember. All right, so the signs and symptoms of cholinergic drug poisoning, they're going to be easy to remember. So we're going to use the mnemonic dumbbells, DUMBELS, 1L. Dumbbells. So D for diarrhea, U for urination, M for meiosis, which means meiosis, actually it's meiosis, is going to be constriction of the pupils, is meiosis, constriction of the pupils. Bradycardia, B is going to be bradycardia, bronchospasm, or bronchoria, which is going to be bronchoria, is just remember diarrhea, think of that. It's going to be a discharge of a mucus from the lungs, bronchoria. So almost like diarrhea of the lungs, right? Discharge of mucus. All right, you're also going to have emesis. E is going to be emesis, vomiting. You're going to have L, lacrimation, which means tearing, lacrimation, tearing, like tearing of the eyes. You'll also have seizures, salivation, and sweating. It's going to be your S. So dumbbells, diarrhea, urination, meiosis, bradycardia, bronchospasm, bronchoria, emesis, lacrimation, seizures, salivation, sweating. Take a picture of it. If you have an iPhone, then press the two buttons that takes a screenshot. If you have an Android, I don't know what to tell you. I used to be an Android person, and then I wisened up. All right, another one that we can use, sludgeum. This is the one that's most commonly used that I've seen, sludgeum. All right, so as I talked about before, our hazmat people, these are the two things that you need to look at. So sludgeum, S, salivation, sweating, L, lacrimation, U, urination, D, defecation, drooling, or diarrhea, which is going to be your mucosal bronchoria, the drooling, right? Also, G is going to be gastric upset and cramps. E, emesis, M, muscle twitching or meiosis. Sludgeum. All right, so the most important consideration is going to be to avoid exposure to yourself. So decontamination may take priority in these instances over immediate transport. So in many jurisdictions, the hazmat team is going to provide that decontamination piece, and they're going to be able to contain the exposure chemical as well, or should be able to do that. So your priorities after decontamination are going to be to decrease the secretions in the mouth and trachea and provide airway support. Keep that airway going. All right, your antidote kits, they may be available for your cholinergic agents. The most common is going to be a duodote, all right, duodote auto injector. So the kit consists of a single auto injector that contains atropine and pralidoxamine. So if a known exposure to a nerve agent or organophosphate with manifestation signs, meaning that we can see that it's interacting with the body or it's causing negative effects of the body, then those signs and symptoms have occurred, then you can use the antidote kit on yourself. If you see those signs in yourself, you can use the antidote kit in yourself. No, it doesn't have to be jammed into your own chest. All right, some other miscellaneous drugs. Accidental or intentional overdose with cardiac medications has become pretty common. I've seen that quite a bit. Children is usually what you see a lot of this in. They're thinking that it's candy, or older patients that forget that and they take the second dose of medication. Older patients that may forget and take a second dose of their medication. It's interesting. All right, so some signs and symptoms depend on the medication that's ingested. And then we want to make sure that we contact a poison control center as soon as possible for these patients. So aspirin doesn't seem like it may be that dangerous, but it can be. So it remains a potentially lethal condition. Ingesting too much aspirin may result in things like nausea, vomiting, hyperventilation, and ringing in the ears. So patients with this problem are likely to have anxiety, confusion, tachypnea, hyperthermia, and then also can end up having danger of having seizures as well. So overdosing with acetaminophen and medications can contain, or overdosing with acetaminophen and medications that contain acetaminophen is also pretty common. Acetaminophen, what is a common drug that we use that has acetaminophen in, or that is acetaminophen?
Tylenol.
Tylenol. All right, and aspirin is considered a what?
Anti-inflammatory. It's an NSAID, isn't it?
Yep, it's an NSAID. Yep, non-steroidal anti-inflammatory. That's right, drug. Non-steroidal anti-inflammatory drug. All right, so acetaminophen, or like your Tylenol, there's called different things, but Tylenol is pretty common. You can have accidental acetaminophen overdose, and it's going to be it can be as serious as an intentional overdose if that happens. So some alcohols, including methyl alcohol and ethylene glycol, are even more toxic than ethyl alcohol, like your drinking alcohol. So both will cause severe tachypnea, blindness, renal failure, and eventually it can wind up causing death. I think I said something earlier that wasn't correct. I had an epiphany, and it wasn't an epiphany. I think I had a moment of clarity, not due to any drugs that I'm taking or anything like that. I'll have to look at it, but I think I said something incorrectly earlier, and I'll have to fix it before our next break. All right, so food poisoning. Let's talk about food poisoning. So food poisoning is almost always caused by eating food contaminated by bacteria. So the organism itself may cause disease. The organism may also produce toxins that cause disease. Food poisoning is no fun. No fun. My wife, about several years ago, I still to this day, tell everybody that she tried to poison me, and successfully she tried to throw the scent off by poisoning herself as well. She put hot chili in the refrigerator, and upon putting hot chili in the refrigerator, it caused the flora and everything else to build up, that bacteria. And when she did that, caused that bacteria in there, the next day I came home from work and I was like, I'm going to eat me some leftovers. Used to be all about some leftovers. So I ate one bowl of chili. She ate 2 bowls of chili. And like I said, highly effective. And ended up getting sick, very sick. Of course, I called my boss, or I called my assistant chief. And I said, hey, I'm going to have to take off work. I can't keep anything down, can't keep anything in. It's a real problem. My assistant chief back then was a nurse practitioner. He was like, well, that's bull. It's like, go to the store and buy as much water and as much, as much water, Powerade, Gatorade, electrolyte, whatever. What do they call it? Oh my gosh, I drink it all the time when I do live burns.
Pedialyte.
Pedialyte, yeah. So buy as much of that as you can carry in a bag, bring it home, then force yourself to drink it the entire night. We got to have you here at work tomorrow. Thanks, boss. So I was a lieutenant then. And I went home, did exactly that. My wife, she was very sick too. We could barely get out of the bed. And ended up, I ended up the next morning, I drank so much of that stuff, so much of the Pedialyte, the Gator, I mixed it all up, just whatever I could mix it up in. And just drank and drank and drank and drank and sick and sick and sick and sick and just trying to get it out of there. And the next morning I got up and was able to ambulate and get around the house and got dressed for work and left. And of course, at some fire departments, if you have the ability to do so, sometimes it's better to be sick at the fire department with certain types of illnesses than back then. Now, if you even have an inkling of being sick in the fire department, people lose their minds. But back then, you could be sick at the fire department and hide out in your room, and then at the end of shift, just hose it down, clean everything up, hose it down with Lysol, and you're good to go. But I was able to hide out. My wife, on the other hand, she didn't drink anything. She didn't hydrate herself appropriately, and she ended up being sick for the next, I think, 2 to 3 days. She ended up still being sick. So, I mean, it goes to show you that, hey, you can wash that stuff out. You just got to stay on top of it and take care of your body. Take care of your body when you have these food poisoning issues or anything like that. I haven't hurt that bad, but ever since then, my wife can tell you I will not eat leftovers. I will not eat leftovers, which is terrible because there are some leftovers that I would absolutely love to eat, but this irrational fear of getting sick again kind of takes the lead. All right. Sorry about that story. That absolutely did nothing for nobody here. So one organism that produces direct effect of food poisoning is Salmonella bacterium. Salmonella. So there's some common causes of food poisoning there. A whole lot of words that are very confusing to say. I did not put any of these words on a test. I'll tell you that. But you are more than welcome to jot them down and keep a hold of them. All right. So moving on still with food poisoning, it causes salmonellosis. And it's going to be characterized by severe GI symptoms within 72 hours of ingestion. And this includes nausea, vomiting, abdominal pain, and diarrhea. So proper cooking kills bacteria, and proper cleanliness in the kitchen prevents the contamination of uncooked foods. So that was one thing, when we did get sick, we didn't get sick immediately. It was the only thing that we had together. I was actually at work at the hospital. And I was at the hospital and we were sitting there and I was working with a patient that had gangrene, and you can imagine, I can't smell, but I could smell that. And I was sitting there and we're working with this patient, and a nurse looked across at me and she said, "You're very green. You look green." And I said, "I am green. And I'm pretty sure that I'm going to use a little bit of leave and I'm going to jet from here as soon as we get this wrapped up." And she was like, "It's probably highly advisable you do so." And I was sweating. I was Mr. Robert Owen. I was diaphoretic. And so I was very much so just sweating profusely. And it was in a cool ER, sweating profusely. I was green in color. I looked like a Ninja Turtle, just not as cool, and was very sick. So I left there, and when I left there, I could barely drive home. I was hurting so bad. So it was an experience that I soon won't forget. So the more common cause for food poisoning is ingestion of powerful toxins called bacteria, or produced by bacteria, often in leftovers. So the bacterium Staphylococcus is quick to grow and produce toxins in food. So foods left unrefrigerated are a common vehicle. This results in sudden GI symptoms, including nausea, vomiting, and diarrhea. Symptoms usually start within 2 to 3 hours after ingestion, or as long as 8 to 12 hours after ingestion. Sorry, I was getting a text message. It pops up on my computer screen. I'm needing a room tomorrow to teach a class. And so I asked somebody if I could borrow their classroom, and they were like, yeah, I don't think it's scheduled. And then another message came and said, there'll be $150, and then sent me his personal Cash App address and said, it's for the company, it's for the kids. We will be doing this class outside, if that's the case. All right, so the most severe form of toxin ingestion is called botulism. And botulism can result from eating improperly canned foods. So the spores of what's called Clostridium bacteria that grow and produce a toxin. Not good. The symptoms are neurologic in nature, so they cause things like blurring of vision, weakness, and difficulty in speaking and breathing. Dysphagia, right? And dyspnea. So often it can be fatal. Often it is fatal, and the symptoms may develop within the first 24 hours of ingestion or as long as 4 days later. So that's pretty quick for a food poisoning. People are funny. So in general, you do not want to try to determine the specific cause of the acute GI problem. You want to gather as much history as possible from the patient and then transport him or her promptly to the hospital. So when 2 or more persons in the group have the same illness, you should take along some of the suspected food if you're able to. If 2 or more food or 2 or more people have the same suspected illness and it be from possibly a restaurant, you may want to contact the restaurant or health department to see if there are others. Okay, because you have to notify the health department of anything that could possibly be widespread. You personally may not, but you may want to mention it so that the hospital can or whoever. All right, plant poisoning. So there are tens of thousands of cases of plant poisonings annually, tens of thousands. So many of these are going to be from household plants that are poisonous if they're ingested. So not good stuff. Some cause local skin irritations, and they can cause effects to the circulatory system, the GI tract, or they can give patients issues with their central nervous system as well. Here's some common toxic plants here. Rhubarb. Castor bean. Nightshade and death carrots. So castor bean. Castor bean actually makes a very strong chemical agent. Does anybody know what that agent is if it's cooked correctly? Castor bean.
Anthrax?
Ricin. Ricin. So you can make ricin out of castor beans. Now the FBI is listening to us. So if we get a random student in here all of a sudden, we'll know. So castor beans, also growing castor beans around the house and what have you, can keep spiders out of your house as well. So I hear. But I don't think it would be good for dogs to eat or anything else, so I don't know if I'd want it. All right, so it's impossible to memorize every plant and poison. I don't know if it's impossible. So let alone memorize all their effects. So you're going to assess the patient's airway and vital signs, notify the regional poisoning center for assistance in identifying that plant. You can take the plant also to the emergency department. Now they have apps for that. Literally, Google, you can take a picture of the plant and it may pop up for you and show. I don't have any plants in here. All right, take a picture of it. Nope, no plants. No philodendrons or duodendrons. There we go. So you can see that your Dieffenbachia or Bachia. Somebody may know that better than I. A, mistletoe. B, talked about that earlier, right? Castor beans. C, nightshade. D, foxglove. E, and rhododendron. Hey, so castor beans look like something very familiar for you 80s and 90s kids, or 70s, 80s, and 90s kids possibly. They look familiar. I'm not saying they are it. Who remembers jumping beans? I looked at that and it automatically reminded me of jumping beans. Did anybody's parents ever buy them jumping beans when they were a kid? If they didn't, I'm sorry. Those were big. Everybody wanted jumping beans. Please don't tell me I dreamed this. All right, I may have dreamed it. Hold on. Hey, wife. Melinda, do you remember Mexican jumping beans? You do remember them? So they were a real thing. Good. Yep, they were a real thing. The Mandela effect did not enter into this. Good. I was just making sure weren't going on the Mandela effect of some sort. You missed out. You missed out on the jumping beans. But you used to get them. You could get them in this little clear container, and if you waited, they jumped and everything. And then, of course, everybody cracked them open and little bug inside of them or whatever. But pretty crazy. I can't see it. It's so tiny. It won't blow up. Mom didn't like it. Of course not. They're kind of weird, but they're so cool. All right, moving on. I can't read. Yeah, Mr. Man, I can't read it. It's too small for me to read. I have blurred vision. Oh, it was a description. I thought I saw it in there. All right, so here's some figures here that show common poisonous plants. Your Jimson weed, death camas or camas, poison ivy, poison oak, pokey weed, rosary pea, and poison sumac. Hey, so did anybody, you see the pokey weed? This is how crazy we were when we were kids back in the 80s and 90s. I don't know why. What was our parents doing? Because I remember taking the pokeweed or the pokey weed, and we would smash it on each other. We'd smash it on each other because it'd leave purple stains on your skin. Who does that? guess that's why we're as tough as we are, or why we're falling apart so much now. One of the two. It's either we're tough or we're falling apart. One of those. That's the Jimson or the pokeweed here is the exact reason. And also having Mexican jumping beans also. All right. All right, moving on. Oh, so the next page. Good to go. All right, so this is what we're gonna do. We're gonna take a 10-minute break, and then we're gonna come back and we're gonna pound out our patient assessment. Y'all think about who wants to go on it today. Hey, we're talking about toxicology. So y'all have seen that toxicology is largely what? What type of care is toxicology? Largely it's supportive care, right? Give them O2, supportive care, prevent shock. So think about that because this is going to be a pretty good one today. Think about who wants to do this, whenever we come back in 10 minutes. Starting now. See y'all in 10. All right, we are back. All right, so who wants to kick it off? Who wants to step up to the plate and knock one out of the park? Not everybody at once. All right. Go ahead. You got your mic on or your mic working? Sure enough.
Chase, can you hear me now?
I sure can.
Sweet.
All right. So let's see here. Let's get her up and going. Dispatch. So come over. You get dispatch for a 48-year-old female that is unconscious in her living room. 48-year-old female found unconscious in her living room by her husband. Go.
All right, so I'm on the way to the scene. Make sure I've got my PPE, so BSI. Get to the scene. Is the scene safe?
All right, so you get to the scene. There's no immediate hazards. You're inside the patient's living room now. You teleported from your truck into the living room. This is what the future of modern medicine holds. There's no immediate hazards. Medication bottles are noted on the coffee table.
So I'm gonna make sure that it's just the one patient.
It is.
Okay. So considering whether I'll need ALS or any additional resources, right now doesn't seem to be any sort of hazardous materials in the area, so I'm gonna hold off on that. Is she lying prone on the floor?
She is. Okay. No, she's laying on her back right now. She's laying on her back, and she's obtunded. She's in an obtunded state, unconscious, and she's slow. She's got slowed breathing.
Okay. Well, on second thought, I'll give ALS a call and have them be on the way to the scene since she's unconscious and labored breathing.
Okay.
And I'll probably consider stabilization of the spine, asking the husband if she fell down.
She did not fall down.
Okay. So I think she'll be okay for now. So I'm going to move on to my primary survey. Patient seems to be sick, and she is unconscious, so definitely requiring AOS. Chief complaint, I'm not sure of that yet, but considering the medication bottles, I might consider some sort of overdose or poisoning.
Okay. So when you check, she's a 48-year-old female. So you verbalized your general impression. 48-year-old female. She's slow breathing. She's unconscious or appears to be obtunded at this time. Obtunded just means severe altered mental status. However, you do an AVPU, and whenever you do a sternal rub, she responds to the sternal rub by pulling her arms up and trying to get away. What do we call that? If she responds to a sternal rub.
To pain stimuli.
Yep. So she's responsive to painful stimuli. So you decide you want to get a Glasgow coma scale on her. She opens her eyes in response to pain. All right. Her verbal response is incomprehensible sounds. Her motor response is withdrawals from pain. So what would her GCS score be?
It's going to be 2 plus 2 is 4 plus 4. It's going to be 8.
Yep, it's going to be 8.
So comatose, slight comatose.
Yep, she's at an 8 right now. So generally in emergency services we say less than 8 intubate. For her, we're just saying she's breathing really slow, right? So she's breathing really slow right now. Assessment of her airway, or you're in the ABCs now. So how do you want to assess that? Sorry, I'm getting ahead of myself.
Moving into 8. Well, first I'm going to make sure there's no sanguination. She seems to not be bleeding anywhere excessively. So yeah, ABCs. Make sure her airway is patent.
Yep, her airway is patent. Breath sounds are slow and shallow.
Okay, slow and shallow. So I'll probably put her on a non-rebreather mask with high flow oxygen.
Okay, so non-rebreather at 15 liters a minute.
Yeah, yes, sir. And then so that's the breathing as well. She is on oxygen. Then I'll move on to circulation.
Okay. So checking her circulation, there's no active bleeding. You check her pulse, it's regular but slow, and then her skin is pale and cool.
Yeah, that's the radial pulse, right?
Correct, radial pulse.
Yeah, pale and cool. That's when it comes to high priority, considering the GCS, and I'll probably go ahead and treat her for shock while I'm waiting for transport or as I'm moving her to the ambulance.
Okay.
Then I'll move on to history taking. So I'll probably speak to the husband at this point since she's not very responsive.
Yep. So who can we talk to?
The family member. You said the husband was present.
That's correct.
I'll ask him, as your, what was the kind of signs and symptoms?
All right. So about 30 minutes ago, is when it started. She hadn't been acting right. She's not responding like she usually does. She's never been like this before. She told me she may have taken her medication twice on accident. But about 20 minutes ago is when this started.
I guess, does she have any allergies that I should be that I should know of?
I'm sorry, say that again. Oh, allergies? No, she doesn't have any. I don't know of any allergies that she has.
What kind of medication was she taking, and is there any other medication that she's currently on?
So she takes diazepam because she's got anxiety and depression.
And that's the medication that she might have taken twice, right?
Right.
Okay. Does she have any pertinent medical history? You said depression. Anything else?
Just the anxiety and depression. That's it.
When's the last time that she ate or had any sort of fluid? And what was it?
All right, so she had lunch about 2 hours ago.
Okay. And was there anything else that led up that she was doing before she passed out? Before she had this incident?
No, just she said she was going to take her medication, and that's. I hadn't seen her because I was looking at my lawnmower. Which to be very rude.
The medication bottle with me.
Okay.
If that's okay. And then I'll move on to my secondary that I like. I'm going to start taking her vitals.
All right. All right. So what vitals would you like?
So I'm going to have to do a full set of vitals. So that's going to be start with her blood pressure.
I guess if I moved you along too, that'd probably help out. Sorry about that. Blood pressure is going to be 90 over 55.
95. Her pulse.
Her pulse is 50 and regular.
You said it's weak as well, right?
Just regular. Right now it's 50 and regular. It's
the respiratory rate.
It's 10. It's still slow and shallow. Remember, you have her on 15 liters of oxygen via normal breather also.
10 breaths a minute.
I'm sorry, say that again.
You said 10 breaths per minute?
Yep, 10 breaths per minute.
Okay. CBG or GBG?
Yep, her CBG is 120.
Oxygen, SpO2?
SpO2 is 93.
Okay, and how much, I guess I forgot to ask, but how much does the patient weigh? Is she big, small?
She's going to be, hold on. Now I'm getting into this. I'm going to give you a good one. So let's say that she's about, let's say she's 202 pounds.
So I'll do a rapid assessment going through all their body parts.
Okay.
Since I haven't looked at that, so going from head, chest, just kind of looking over here.
Okay, so what we're gonna want to do is a focused assessment, right? Because this is what we got. Usually our detailed assessments are going to be for our trauma patients, but with your focused assessment, you can look at other body systems as well to see how they are affected. So you could look at your cardiovascular. We already know she's got a slow and regular pulse. Neurological, she's obtunded, and she responds to painful stimuli. Her skin or integumentary system is pale, cool skin. Reproductive, we're not worried about that. Pulmonary, slow, shallow breathing. Musculoskeletal, she's got no deformities or injuries noted. GI, nothing, not applicable. Psychological, social, the husband is extremely worried. We'll say she's obtunded, so we can't do her psychological. All right.
All right. My full impressions of this patient at this moment, possible overdose.
Okay.
Does have a pretty low hypotension.
Okay.
So, yeah, interventions, put her on high flow O2. Is her oxygen increasing?
It is. So her oxygen increased to 95%. Her blood pressure also went up to 100/65. Her pulse is at 60, and her respirations are now at 12.
I'll put a blanket over her to treat for shock, and then I'll reassess her every 5 minutes, making sure to check the ABCs, make sure that the airway stays patent.
Okay. Well, while you were en route, she started to come to, and started to become conscious and trying to figure out what's going on. Now that her oxygen level's gotten back up and it's doing well. So is there another intervention that you may want to look into?
Check her pupils. I'll probably check her pupils. And
okay. Is there another medic or another intervention though that you may want to look into?
Okay.
So like for a benzodiazepine. What may work out for this?
I don't know.
Okay. So possibly activated charcoal.
Activated charcoal. Okay.
Yep, if it's within your scope, so you'll call up for it, right?
Control, so she's awake and able to take it orally. Yeah, activated charcoal.
Okay.
I'll ask her, of course, whether she wants to take it. Probably
absolutely do. I love that stuff. All right.
Yeah.
All right. So did all that. Checked her out. She's got her blood pressure's holding steady.
A quick question though. At this point, is she still considered unstable?
Yes. So at this time, she's stabilizing. Well, she's improved. So she's improved. She's still not stable because remember what I said. You may not always stay at that state. So since just because remember what we talked about also, just because they're stable or just because they're hemodynamically stable at the time doesn't mean they're absolutely stable, right? Because their toxicology that could change at any minute. So we're going to assess her how often?
Every 5 minutes or
every 5 minutes. Great. All right. So you showed up at the hospital. You see the wonderful Nurse Chad. You see the wonderful Nurse Chad, who comes up and he's like, yeah, man, what do you got?
Good evening, Nurse Chad. So I've got a 48-year-old female. She was unconscious when we arrived on the scene. Husband says that she potentially took a double dose of diazepam. Vitals, when we first took her vitals, blood pressure was 90/55. Pulse was 50 and regular. Our respiratory rate was 10 breaths per minute. CBG 120 and SpO2 93%. We can put her on high flow oxygen, non-rebreather mask at 15 liters a minute, and treated her for shock, providing her with a blanket. I've got the medication that she took with me, so I'll hand that over to him. And she became conscious during transport, where we then gave her some activated charcoal to potentially counteract the medication she took.
Okay. All righty. Awesome. Her
vitals seem to be stabilizing after these interventions.
Awesome. Sounds good. Gave oxygen, supportive care, activated charcoal. Good stuff. All righty. All right, let's continue on. Awesome job. Appreciate it. Sounded great. Where are we at? All right. Question number 1. Which of the following questions is of least pertinence for the EMT to ask a patient who intentionally overdosed on medication? Hold your answers. Hold your answers. All right, go ahead. All right, D. Okay. All right. Answer is D. Good job. All right, a 30-year-old male who ingested an unknown substance begins to vomit. You should A, B, C, or D. Hold your answers. Hold them. All right, go ahead. All right, D. Answer is A. So, collect the vomitus and bring it to the hospital. So, ingest an unknown substance begins to vomit. You should. So, remember, the 30-year-old patient who's ingested an unknown substance begins to vomit. You should. So, we're not guaranteed that he's unconscious or anything like that. So, you don't want to be suctioning on somebody that's trying to actively vomit. We may hand this person an emesis bag, though, for that. But we'll collect the vomitus and bring it to the hospital with us, and we'll do a collection of the emesis bag. So A is going to be it. Most definitely, you do not want to get suctioned while you're still trying to throw up. That wouldn't be good. But I saw where y'all were going. With it. All right. So when caring for a patient with a surface contact poisoning, it's important to remember what? A, B, C, or D. Hold your answers. Hold your answers. All right, go for it. Let's see them. All right, there you go. Avoid contaminating yourself or others. Great job. All right, so most poisonings occur via blank route. A, B, C, or D. Hold your answers. All right, let's see them. All right. Got a lot of B's there. B's, 80%. Good job. Question number 5. How much activated charcoal could you administer to a 55-pound child who swallowed a bottle of aspirin? A bottle of aspirin. All right, go ahead. Let's see it. We got all B's. Okay. B, 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 B. All right. It is B. 1 gram per kg, right? 1 gram per kg. All right. Awesome job, ladies and gents. All right. So, closing out for tonight. Do we have any questions for me about tonight's lecture? Any questions about tonight's lecture? All right. If not, then your class code tonight is going to be 1996. 1996. 1996. So, in 1996, the Health Insurance Portability Act, known as HIPAA, 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 is signed into law in the United States. So that ensures the privacy and the security of patient health information, including EMS records. If y'all remember back what it was at Chapter 3. So HIPAA is going to be a landmark legislation that's going to protect the privacy and the security of patients' health information. So the law is crucial in the context of emergency medical services as it ensures that patients' sensitive medical information, including EMS records, is protected from unauthorized disclosure or access. So HIPAA compliance is essential in maintaining patient confidentiality and privacy in the EMS system. All right, 1996, your class code. Upcoming this weekend, Saturday, September 2nd, 2023 at 11:59 p.m. It's going to be locked out after that. Chapter 21, Allergy, Anaphylaxis, Emergencies, and Platinum ED, and Chapter 22, Toxicology, Emergencies in Platinum ED. So 21, I think Chapter 21 in there, I think it's labeled Immunology. I think it's labeled that, Immunology, instead of Allergy and Anaphylaxis. And then Toxicology, Emergencies is going to be number 22. All right, so coming up next week, or on Tuesday, next Tuesday, we'll have Chapter 23, Behavioral Health Emergencies. So after Chapter 23, that'll be the close of this module, and you'll be free to take the module test after that. So the module test will be opened up, and it'll close that next Monday on September 11th. But we're still going to start into the next module on Thursday. We'll be into the module after while that test is still open. So don't get confused or anything. So Chapter 23 is going to be our last chapter of this module. After that, feel free to take the test, the module test, and you'll be good to go then. All right. So there you see it, 1996. What's due September 2nd? Remember, allergies and anaphylaxis emergencies. I think it comes up as immunology. And then coming up next, Chapter 23 on Tuesday. Other than that, I'm going to be on for just a little bit after I stop recording. If you don't need me, feel free to go ahead and bounce on out. I appreciate y'all stopping by tonight, and y'all have a great weekend. Night-night.